Doctor, we are live now.
Good. Okay, so good evening, respected seniors, colleagues, and all the wonderful and dynamic residents who are logging in for today's class. It gives me immense pleasure to welcome you all for yet another master class of the online postgraduate teaching program Kaksha. So Kaksha is a PG teaching program envisioned by ROS which will cover all the major topics over a period of next 2 to 3 years of the current curriculum of postgraduate ophthalmology program. We'll be bringing the best of national and state faculty experts to share the knowledge and interact with you. The residents too also are encouraged to put forward their doubts in a fearless and a frank manner with the guest speakers and the panelists and type their queries or raise their hand and we'll get back to you. Coming to this class, we have today with me my very dear friend Dr. Akshay Nair from Mumbai, who will be thread bearing a major topic and I guess a very important exam case also, proptosis. I and Akshay go back by many years, many decades now, to our good old Chennai days in Shankar Nitralaya. Dr. Akshay is an authority and a very well-known figure amongst the oculoplasty circles, not just in India but around the globe. Just a brief CV about Dr. Akshay Nair. He's an ophthalmologist, author, clinician scientist based in Mumbai. He is currently the director of ophthalmic plastic surgery and ocular oncology services at the Mumbai unit of Dr. Agarwal Group of Eye Hospital. His area of expertise is in oculoplastic surgery, ocular oncology, and more specifically, he is known globally for his pioneer work in mucormycosis, a real life-threatening fungal disease. We also saw a sharp rise in numbers following COVID-19 pandemic a couple of years back. He has been honored with the achievement awarded by the American Academy of Ophthalmology and Asia Pacific Academy of Ophthalmology in 2019. Dr. Nair has authored of more than 130 Indian scientific papers and also contributed in 15 scientific textbooks. He features in the top 2% scientist list based on a paper published at Stanford for 2022, which is a huge achievement and which actually lists the most cited uh, scientists globally. And he's the first non-American international member to be inducted in 2023 into the American Academy of Ophthalmology One Editorial Board for a 5 year period. He's been a recipient of multiple travel grants and multiple posters and paper awards in the field of neuroophthalmology and ocular oncology in AIOS and American Academy. He serves as an elected member of the Executive Council of Oculoplasty Association of India and the Asia Pacific Society of Ophthalmic Plastic and Reconstructive Surgery. He lives in Mumbai with his lovely wife Rima, a dentist, and their two children. Now I welcome the ROS President, Dr. Khilani Sir, President-elect Dr. Sanjeev Desai, and the Dynamic Secretary from Jodhpur, Dr. Ghulam Ali. Good evening, sir. And for today's class, we have two hot seat presidents with whom Dr. Akshay is requested to interact. Dr. Pooja, Dr. Daksh. Pooja and Daksh, are you here?
Yes, good evening, sir.
Good evening.
I'm here.
Okay. All our final postgraduates and NSR from different colleges in Rajasthan. There'll be a grand quiz with exciting prizes at the end of this class. So all the residents are requested to keep a strong vigil and listen carefully. I hand over the class to Akshay. Akshay, you can start you can share your screen and start the class.
Right. Thank you so much for that fantastic introduction, Vishal. Although I must say that I live in Mumbai with my lovely wife. The word lovely was not in that introduction. Anyway, jokes apart, thank you so much. It's an honor to be invited to present here, especially given the previous speakers who've been true stalwarts in the field. Thank you so much to the office bearers, Dr. Ghulam, amongst others, who are present here to speak on a topic which is very important for fellows and residents and even practitioners who are beginning in practice. So I'll be discussing multiple cases, cases that I, as a resident, as a fellow, as a consultant, have treated across the past 10, 12 years that I've been in practice. So a lot of these affiliations cases would be from these institutes. Can everybody else mute?
1 second, I'll just note everybody.
Thank you. So the talk overview is going to be how to approach a case of proptosis. What do you do when you work, when you talk about working up and coming to a diagnosis of exophthalmometry or proptosis, which includes exophthalmometry. A significant portion of this talk is going to focus on imaging and how to interpret imaging, basically CT scans primarily, as well as MRI. What kind of scan is needed in what kind of patients and what clinical scenarios. And finally, we will be also dealing with surgical and medical management of conditions that result in proptosis, including a surgical approach to orbitotomy. So before I start, Daksh, just simple question: is there any difference between proptosis versus exophthalmos? Because as a resident, I used to use these words interchangeably.
So for proptosis, I think there must be it can be physiological also, but for exophthalmos, there must be some pathological condition underlying which leading to the proptosis.
Okay. Pooja, do you want to give us a better answer or refine it?
Proptosis is a general term used for the abnormal protrusion of the eyeball, and the exophthalmos is particularly used for the thyroid eye disease. The proptosis associated with the thyroid eye disease.
That's correct. That's very well answered, and this is a very common question that you'll be asked in your examination. Is that proptosis is outward deviation of the eyeball, whereas exophthalmos is a term that is not used commonly now, because exophthalmos refers to proptosis or outward protrusion of the eyeball when it is particularly associated exclusively with thyroid eye disease. So other cases of proptosis should not be referred to as exophthalmos, but as it is in general, we are seeing that the term exophthalmos is now outdated and not used commonly. So let me put across 3 cases, and we'll come back to these 3 set of cases after we go through the entire presentation. One is a 55-year-old female with a 4-month history of rapidly increasing proptosis in the right eye. This is associated pain and redness. You can see the red congested eye along with chemosis. Whereas the middle patient is a 46-year-old gentleman with right eye proptosis since many years. He's been gradually increasing, painless, and 6'6" N6. Whereas this is a child, a 5-year-old male child actually, who comes with an eyelid or an orbital swelling with proptosis, which is pushing the globe down and out. The parents say that there are episodes, days when it goes and settles very nicely, but there are days when it exacerbates and it looks very puffy and swollen. It worsens whenever he has a cold, but is rarely associated with pain. So now, based on these symptoms and appearances, can we conclusively tell what is a diagnosis or what is the final outcome? And that's going to be difficult. So, which is why we need to understand what is a tailor-made approach when it comes to proptosis or coming to a diagnosis in this case. So how do you approach a case of proptosis or any orbital case? You send for a CT, read the radiologist report, arrive at diagnosis? No, that's exactly not how not to approach a case. And hopefully by the end of the next hour or so, we'll have a better idea of what to do. So first thing, when we see that a patient has a prominent eye, we need to ask ourselves, is this proptosis in the first place? Now for that, let me show you a case. This is a 23-year-old female. She's come to us and said that I'm going to get married in the next 6 months or so. One eye is larger than the other eye, and it's been more prominent over the past 7 years. Is this, I want to put it back. I want to make it look normal. Is this proptosis? We advised T3, T4, TSH, got the thyroid panel, referred to an endocrinologist. Everything is normal. We're wondering what to do. And then we sent her for a CT scan. And guess what the CT scan showed up? We didn't actually need to send a CT for scan, but we still sent her for a CT scan. You can see one eyeball is huge, is larger than the other. All we needed to do was turn the page and see the refraction. She was -1 in the right eye and -9 in the left eye. This is axial myopia. This is pseudoproptosis because the length of the eyeball is larger in myopes. And this is unilateral myopia, which caused the eyeball length to increase, which deceived a lot of us. So this is called a pseudoproptosis. So before investigating into causes of proptosis, the first thing to find out is this really proptosis? And cases that can confuse you are ophthalmos, where the eyeball or the corneal diameter specifically increases, giving you the illusion that the eyeball has increased in size. Contralateral ptosis, lid retraction. So if one eye is ptotic, even the normal eye may appear to be proptotic, especially if the ptosis in the contralateral eye is mild. Contralateral enophthalmos. Similarly, if someone who's had a fracture in the right eye, they will get enophthalmos. The eyeball shifts inwards, giving the illusion that the left eye is proptotic. A shallow orbit, as you can see in the middle set of images in Cruzon syndrome. Lid retraction can give you the impression that there is proptosis, even though the position of the eyeball may be equal, but the lid going up, which shows you scleral show superiorly and inferiorly, can lead you into believing that this is a case of proptosis. And finally, phthisis, or rather prephthisical eye, when one eye appears smaller or shrunken in size, even though it may have no vision, you may get confused and think, hey, is the other eye proptotic? So first basic ground rules of the ground is to make sure and confirm that this is proptosis or not. Now, once that is done, history is very important, because history in terms of the associated symptoms, the duration, the age group, and episodes of pain, exacerbation, all of them give us directions as to which way this is going. In history, we look at laterality, whether it is unilateral or bilateral. In duration, we need to find out whether it is hyperacute, subacute, acute, chronic, or over years. And of course, symptoms such as pain, diplopia, and whether it's been a rapidly aggressive course or a waxing and waning course. Now, if it is a case of proptosis that is increased over a matter of days, it usually is infective. Or it could be an exacerbation of a previous condition, which is a chronic condition. So it could be an acute or chronic condition. Like this child who has got a bleed in a lymphangioma below, or the patient above, who we'll come to a little later, who's presented with proptosis and severe chemosis. If you suspect it is infective, you must seek a focus of infection. The infective focus could be anywhere, but most commonly lies in the vicinity, which is the paranasal sinuses, which usually causes an infection in the orbit. If it is a question of weeks or months, this could be a dilemma, because it could be benign condition like thyroid eye disease or orbital inflammatory disease, which can increase suddenly, but it's technically a benign condition. Or it could be a malignant condition, which is showing a rapid progression. Now, benign conditions that show rapid progression are typically bilateral, but thyroid eye disease and orbital inflammation can also be unilateral. Episodes of exacerbation, again, like lymphangioma with bleeds, can be seen gradually progressing even in a matter of weeks. And finally, we come to benign tumors, which usually take years or months to gradually progress, usually indicating benign. But remember that in the orbit, there are multiple lesions like solitary fibrous tumors, adenoid cystic carcinomas or lacrimal gland tumors, or even schwannomas, which can be benign, but then can undergo malignant transformation. So if you have a mass that is growing slowly, but shows a rapid increase in the past few weeks or months, that is again a red flag. The time of onset is important to know, because there are certain tumors that are congenital, which are usually benign or developmental tumors. Tumors of the orbit which come in infancy or childhood, like rhabdomyosarcoma or retinoblastoma, are typically malignant tumors. And these are a set of tumors that are rarely seen in adults. So you need to know the onset of this to be able to classify them or to come to an etiology. Now, pain and double vision, pain and diplopia are signs that associated with inflammation or invasion. When we talk about inflammation, it could be myositis, it could be perineuritis, it could be scleritis, dacryoadenitis. Any of these structures within the vicinity of the eyeball or the eyeball itself could get inflamed, leading to pain and proptosis. But when we talk about invasion, We are talking about a tumor which could be invading the lacrimal gland, the extraocular muscles, or the optic nerve sheath. Again, this could be a primary tumor or a metastatic tumor uh, that causes invasion leading to pain and diplopia. Pain in the lacrimal gland tumor is usually indicates that there is a perineural invasion of the tumor, suggesting that it could be a adenoid cystic or any other malignant tumor. All right, so I'm going to go back to Dr. Daksh. Dr. Daksh, can you tell me what is the most common cause of uh, unilateral proptosis in adults?
So for adult, it is a thyroid diseases.
All right. I think it was Dr. Pooja Kesavani, right? So Daksh answered the most common cause of unilateral proptosis in adults. Can you tell me what is the most common cause of bilateral proptosis in adults?
Same thyroid eye disease.
That's correct. So you shouldn't have taken so long. It was a googly. Thyroid eye disease remains the most common cause of proptosis, both unilateral and bilateral in adults. Now, this course, like I mentioned, whether it is stable, progressive, with periods of regression or recurrent, all indicate to an etiology, which it could be tumors typically have a progressively increasing course of proptosis. Cases where there is a rapid progressive increase is malignant, and benign would be slowly increasing. Now, it's important to know, to document diplopia, postural variations, URTI, or fluctuations with respiratory tract infections, and waxing and waning courses. So again, I'm going to throw this question to either of you two. When we talk about posture, can you name at least one condition where there is a variation in proptosis based on the posture that you adopt?
Sir, hemangioma. It can be hemangioma.
So not exactly a hemangioma, but you're close. It is a vascular lesion that we're talking about. Dr. Pooja, you want to take a chance and see?
Cavernous sinus.
Cavernous sinus. All right. So we'll fold the page on this one and come back to it a little bit to understand why a postural variation can cause an increase in proptosis. The next thing and the most important thing is examination. Now, the examination of a case of proptosis is no different from that of any other patient that comes into your clinic. You have to check we finished the history, the onset, the progression, associated symptoms, and got the main complaints from the patient. And now we need to examine the uncorrected visual acuity, the best corrected visual acuity, which includes the distance in near vision, check the pressures, document the motility, and the key for us is color vision proptosis, which is measurement of proptosis called exophthalmometry. Document your Schirmers, because lacrimal gland involvement causing lacrimal gland tumors can have a deranged Schirmers. Check the pupil and iris. Check the adnexa, the conjunctiva, any orbital rim or deficit or any structure that is palpable. A slit lamp examination followed by a fundus examination. This is a standard pro forma for basically every case. The only thing that we add here is exophthalmometry. Now, inspection is important. Now, this is a patient who we see with right-sided proptosis. Now, you can see that there is congestion, and on a closer look, you can actually see how the extraocular muscle, the lateral rectus, is almost delineated there, and there is an increased hyperemia across the course, and just short of the tendon, there is it stops just short of the insertion into the globe. So these are cases of myositis, which could be thyroid eye disease or autoimmune or orbital inflammatory related. And when we did an MRI, you could see that there is increased thickness, which is symmetrical on the medial and lateral rectus, but you can compare the thickness of the muscles on either side, suggesting this is unilateral thyroid eye disease. Similarly, this is another child with an orbital bleed, and you can see when medially over in the proptotic eye, there are focal areas of subconjunctival bleed. which give you an idea that, yeah, this is a vascular lesion that you're dealing with. So an examination is very important. Any of you or anyone can also, type into their chat box, what is the, there are two photographs here, one on top and one below. Can you guys tell me what is the specific view that is being captured here? What is this view called?
Navzigus.
Navziger's view. That's incorrect. Let me see. Someone in the chat box has said.
So
Priyanka
worm's eye
Agrawal
view.
has said worm's eye view. That's right. That's correct. Worm's eye view is correct. So Navziger view or Navziger way of examination of exophthalmometry is the exact opposite, where you have the patient sitting in front of you, and from behind you move forward, at the same time extend the neck of the patient, and the way or Navziger's method of assessing proptosis is to see if any one eyeball comes into view before the other. If both eyeballs or both globes come into view at the same time with the patient looking up, that indicates that this is not proptotic. But if one eyeball is more in view when you look from top bottom, it's a positive sign of proptosis. It's Navziger technique or Navziger's view. This is called a worm's eye view because it looks like a worm who's on the floor looking up and seeing the sky, and this is what they would see. Now, when you click a photograph on worm's eye view, the tip of the nose should be placed between the eyebrows, and the focus of the camera should be on the corneas. Your focus should never be on the tip of the nose because that blurs out details of the eyeball, and you will be able to judge fairly well the amount of proptosis that there is. Now, in measuring proptosis, not only do you need to document the amount of proptosis, you also need to note the direction in which there is proptosis and associated findings when it comes to palpation and auscultation there. So proptosis can be objective, where you measure it using an exophthalmometer, and document that one finding on that one day. It could be comparative when you measure it over two different settings, or serial when you measure it over a period of time. All right. Again, this is a question for the students. Can you name the two exophthalmometers that you see? The one on top is number one, and say the one at the bottom is number two. All right. So Kavita has mentioned Ludes and Priyanka has mentioned
Turtles.
All right. So which is Ludes, which is Hurtles?
The top one is Lute, sir, and second one is
Ludes,
Turtles.
and the second one is Hurtles. And both utilize the presence of the bony landmark, the lateral orbital rim, as the place to either fixate the exophthalmometer and to check the relative position of the anterior surface of the cornea with reference to the lateral orbital rim, and the distance between the lateral orbital rim and the anterior surface of the cornea is your exophthalmometry measurement. All right. So one quick question: what is a normal exophthalmometry range in the Indian population, or the baseline that is considered normal?
21 mm, or the difference between both the eyes is 2 mm.
That's correct. So 21 mm is actually on the higher end of the range. I see in the chat box, Dr. Kavita has mentioned 105.
21, sir.
So 105 is actually the interlateral canthal distance, or the baseline that you see, interpupillary distance, sorry, between the two prongs of the Hurtles exophthalmometer, and that can vary. So that is never a fixed range. But for the Indian population, 19 to 21 is considered a normal range. In some patients, especially in southern India, we see that the range goes down to as low as even 13 or 14, which is normal. But a difference of 2, more importantly, between the two eyes in the absence of any refractive error or pseudoproptosis is the red flag, because that tells you that there is possibly proptosis. So I'm going to run a small video that gives you an overview. This is shot at LV Prasad Eye Institute. So this is using Hurtles exophthalmometer. And like I said, what is measured is the distance from the lateral orbital rim to the anterior surface of the cornea. So the two the two fixed points are kept at the lateral canthus. Patient is asked to look straight ahead, and the reflection is seen. And it is more important to have the patient at the same eye level as you. Now, this is important to eliminate parallax. The other way to eliminate parallax is to have the patient's face brightly lit, place the exophthalmometer with the minimum possible distance between the two lateral canthal edges of your exophthalmometer. The base is measured here by keeping the two metal bases at the lateral bony rims. Adjust it and document the distance between the two such that you know it is now at 98 as you saw that. Can you be on mute, man? Yeah. Once that is done, you write down the baseline value, which in this case was seen to be, say, 108, which is your base. And then when you examine the left eye, you close your left eye and see with your right eye. What you need to see is to coincide the two red lines. And once you coincide the two red lines, measure the anterior surface of the cornea according to the graduated markings on top. So now you have eliminated parallax error by merging the two red lines. Exophthalmometry reading is 16. So 16 will be your one eye. And now again, do the same for the other eye. While you are examining the patient's left eye, right eye, you can close your left eye or your right eye based on which is your dominant eye and document the finding. So that every time you write it, you mention H, that tells you it's Hertel, a baseline which was 105, so that when someone else is measuring and they have your file or findings in front of you, they can keep the same base intact and document the measurement. Now, as I said, comparative exophthalmometry is when you use the same exophthalmometer and compare the patient's findings over a period of time. I think that is a very good understanding of how to do exophthalmometry. Once we know how to perform exophthalmometry, we need to look at the direction of the proptosis, because that gives us a clue as to what is the mass or where could be the mass that is causing proptosis. So proptosis can be axial, which is in the straight axis where there is no directional deviation of the globe. It comes straight forward out. Abaxial is where it is directed in one particular direction, which could be upward, downward, medially, laterally. In the sense, it is not along the straight axis of the optic nerve. So typically, axial are thyroid eye disease or intraconal tumors or optic nerve sheath tumors or optic nerve tumors that push the globe out axially. Whereas abaxial tumors are either ones that are from the inferior side or medial, lateral, pushing the globe outward as well as downward or upward, exactly in the opposite direction as compared to the location of the tumor. Now, this is a non-exhaustive list. This is a suggestive list that if you are suspecting a mass medially, most likely it could be a subperiosteal abscess. If it is superomedial, it could be an osteoma or a frontoethmoidal mucocele. Similarly, superolaterally, usually you see dermoids or lacrimal gland tumors. And inferiorly, you will have a maxillary sinus carcinoma or a granuloma, fungal granuloma arising from the sinus that comes up. And like I mentioned, cavernous hemangiomas, schwannomas, solitary fibrous tumors are well circumscribed axial intraconal tumors, along with optic nerve tumors and AV malformations that cause axial proptosis. Now remember, lymphoma, metastasis, and orbital inflammatory disease can affect any part of the orbit, including the extraconal and intraconal components, and therefore proptosis is variable in these conditions. Now, when you examine and palpate, you have to look for the orbital rim, whether you can palpate the rims or not, because that in cases of trauma, you may be able to feel a bony defect or a rim or a step deformity. Check for tenderness, pulsations, or any thrill that you're able to palpate. And also may check in cases you suspect tumors for regional lymph node status, because if they are enlarged, it tells you that it could be an infective or a tumor related condition. So again, to our hot seat residents, can you name a couple of conditions where you would expect to see pulsatile proptosis, or at least name one condition where you may see pulsatile proptosis.
The carotid cavernous fistula.
Carotid cavernous fistula would, okay. In all cases of CCF, would you expect cavernous? Would you expect pulsatile proptosis?
No, sir, in the direct cases.
In direct
Cavernous
cases, you'd expect
thrombosis, sir.
cavernous sinus thrombosis. Okay, just give me 1 second.
Sir, sphenoidal.
Sphenoidal. Yeah, so I think we got one answer from Dr. Siddhi, who said neurofibroma or meningiocele. So neurofibroma is an answer I'll take, mainly because it is a condition where the lateral wall of the sphenoid orbit, or basically the greater wing of the sphenoid, is absent, and that causes the dura or the meninges to bulge in, and that can be seen causing a pulsatile proptosis. In CCF, unless it's a very high flow direct CCF, we would not see pulsatile proptosis as much as we'd be able to appreciate the bruit or the thrill of it. So that is correct. Finally, because we're talking about the orbit and not just, focusing on proptosis, I'll talk a little bit about, this is like a checklist for a case of trauma. If you are called in the emergency and say, hey, this patient, I think, has a fall, is there an orbital fracture? You have to make sure you've documented these 8 things in your file. Check for the intact orbital rims, and if you can mention the orbital rims palpated, intact, or whether you can feel a step deformity. Crepitus. Crepitus is when there is air, or crepitus is basically when you can feel the crackling sound of air, which air in the subcutaneous planes is basically emphysema, and when you can palpate those air pockets and feel an audible sound, it indicates crepitus. Document motility if there is any diplopia or not, and also mention if the patient has any trismus. Trismus is inability to open the mouth fully, or difficulty or painful mouth opening. It suggests that apart from the orbit, even your mid-face bones, the maxilla, the mandible, the frontal process of the maxilla, there could be a tripod fracture. All of these are involved. Check for enophthalmos. Enophthalmos is the exact opposite of proptosis, and in fractures, when there is a floor or a medial wall fracture, the orbital contents, the extraocular muscles and the fat tend to fall into these bony defects, causing enophthalmos. And finally, mention if you've assessed infraorbital hypoesthesia or any tingling or numbness sensation, which can extend all the way down to the upper teeth, especially the canine and the lateral incisors, which are supplied by the infraorbital nerve. So this is a checklist for your trauma cases that you have to, mention that. CCF, you must document, especially when you suspect a case of CCF, auscultate and check for thrill. And this is what I want to come back to. We've spoken about cases where we'll see a variation in the posture. So this is usually either in cases of orbital varices that we see that when the patient bends, or when there is an increase in intrathoracic, intraorbital pressure, such as in the Valsalva maneuver, you will see that the proptosis is increasing and the eyeball comes out. Once you see a case of Valsalva and increase in proptosis when the patient bends, or when they do blow their nose and increase the intra-abdominal, intrathoracic pressure by doing a Valsalva, you'll never forget it. I'll run it once again. You can see how well it pops out. So in cases where you're doing imaging in these patients, make sure that you inform your radiologist that you would want slices to be done with the patient doing a Valsalva maneuver, so that you're able to document the increase in the size of the varices. Again, things like conjunctivalization of arterialization of conjunctival vessels, and a very, very prominent vasculature in the anterior segment, blood in Schlemm's canal, are all indicative of CCF. Also in the iris, you must look for Lisch nodules, which indicate that this patient could have neurofibromatosis. So once you've done your assessment in terms of your history taking and your examination, then you come down to a big chunk of what our understanding is nowadays based on, which is imaging. So in this overview of imaging, I'm going to talk a bit of CT scans, MRI, X-ray, and what do you order and when do you order, and we'll go through a few case scenarios. So CT scan basically is ionizing radiation where there is an imaging source, which is an X-ray. It's identical source of radiation, which is X-ray. The X-rays pass through the body based on the density of the tissues that are obstructing the passage of the rays, which is soft tissue versus bone versus metal. There are detectors at the exact opposite end towards the emission of the X-ray beam. And that is how the image is produced. Pretty much like how this diagram shows a shadow being cast by a bunny. So there is a patient in the CT scan, and each of these are lines that you see all around are detectors that are rotating. And there is a single point of X-ray tube, which is giving out a beam of X-rays. And based on the position of the patient and the attenuation of the rays, the detectors at the back or the opposite end get those images, it collates them together and creates a CT scan. In comparison, an MRI is not an ionizing radiation. So if a patient is pregnant, an MRI is a safe mode of investigation. It basically runs on the principle that hydrogen is the most abundant element in the body. It has a single positively charged proton that spins around its own axis and creates a small magnetic field. Basically, it behaves like a bar magnetic, and these protons will align themselves according to the external magnetic field. So a large electromagnetic field is created in an MRI machine. All the protons then elevate and go up to a high energy level. The external magnetic field then is turned off. And then as these the electrons come down from a higher energy level to a lower energy level, they give off their energy in the form of a signal, which is then detected as the MRI signal. Now, based on what kind of tissue these protons are present in, whether they are in solid, whether they are in a liquid condition, whether they're tightly packed, as in bone, or in a tumor with low diffusion, we are able to interpret the signals and see it. So in a case of orbital tumor, what do you do? CT or MRI? In many cases, CT is still preferred because it gives us a clear understanding of the bony architecture with respect to the periorbital structures. There are indications for each, but a recent survey of oculoplastic surgeons in the US, the ASOPRS, in 2018, showed that 68% of them still prefer a CT scan as the first investigation in a case of proptosis. When do you particularly choose MRI? When you want to look for better neuroanatomy, when you want to look for cranial nerve, specifically the optic nerve, when you've seen a large intraconal mass, but you can't see the optic nerve clearly in a CT scan. And that's when you tell the radiologist, hey, I want an MRI with contrast because I want to delineate the mass separate from the optic nerve. That's when you'd get an MRI. If you suspect that the patient has an orbital foreign body, could be metallic, don't advise an MRI. Remember, the patient goes into a giant magnet, a metallic foreign body, especially a ferromagnetic body, will be pulled out immediately. Cystic lesions with fluid levels or vascular lesions, MRI gives you better anatomy. And finally, intraocular tumors, MRIs are preferred. X-ray has very limited use. It's a two-dimensional study. Remember that no longer are X-rays advised for fractures. So if you have someone going in advising a fracture, recommend them gently that perhaps CT scan is a better indication. However, in a low resource setting, when it is urgent to know if there is the presence of an intraocular or an intraorbital foreign body, you can get an X-ray done, at least gives you the idea or a screening tool to know whether there is an intraorbital or an intraocular foreign body. Now in CT scan, there are different things that you see. What you see on top are soft tissue windows, where the bone appears intensely white because of attenuation or averaging artifact, and soft tissues are seen uniformly the same. Whereas the image below what you see is better outline or better anatomy of the bone, and that is called a bone window, and what you see on top is called a soft tissue window. In every CT scan for the orbit, it's important to have both, Because as you can see in a soft tissue window, bony details are not as clear in terms of whether is the bone sclerotic, is the bone thick, is there bony erosion. Whereas in the bone window that you see below, you can clearly appreciate the eggshell kind of appearance of the tumor in the roof of the orbit, but at the same time, no soft tissue details are visible clearly. So always get both of these and go through both of them. So what do you request to the radiologist when you want a CT scan? You want to tell them that you want the orbit to be scanned. Oftentimes we make a mistake, or when it is not indicated, we advise CT brain plus orbit. Remember that a radiologist will always do screening cuts of the brain to see if there's any gross abnormality seen. And it also saves their time of not having to go through the brain specifically when there's nothing suspected in the brain. So if you're looking at a trauma or a case of an orbital tumor, insist that you look only for the CT orbit. Remember, the ideal plane for screening is or slice thickness for screening in a CT scan is 2 mm cuts. Mention that you want coronal and axial slices, and whether you want contrast or not. If you're suspecting trauma, contrast is not needed. If you're suspecting a vascular lesion or metastasis or tumors, yes, contrast is needed. Special modifications, like we mentioned earlier, you want a scan with the patient doing a Valsalva maneuver, are things that you need to tell the radiologist. So what is a coronal slice? What is an axial slice? If you see, it's like a loaf of bread that you are slicing up into multiple pieces. Now, these slices are 2 millimeters apart. So when we say 2 mm cuts, the whole, like say, for example, the skull is going to be sliced at intervals of 2 millimeters. So you will see images at intervals of 2 millimeters. Now, front to back is coronal. On two halves of each other, that is right and left, is sagittal. And axial is transverse from back to front. So that's how you would see these. If you always want a coronal and axial plane. Sagittal planes are 3D reconstructed planes on a CT scan, and you really don't get much information except for when you're looking specifically at a floor fracture to understand where the posterior strut is. So, like I said, standard is for 2 mm in the orbit, especially unless you're looking for, say, a bony fragment at the apex. At that point, you will tell them 1 mm cuts. Remember, if you tell your radiologist 1 mm cuts, you're going to get so many films that you have to go through that it's going to be a tough ask even for you to interpret those scans. And it increases the time for the work for everyone. Contrast, like I mentioned, is meant primarily to look for blood vessels, to look for enhancement in cases of inflammation or metastasis, or for leakage when there is active inflammation, like you see. And in these cases, like a CCF, where you see a large dilated superior ophthalmic vein, compare the size of the superior ophthalmic vein on the left versus the right, and you can see that. And this comes through specifically in contrast enhanced images, where you tell the radiologist to do that. We've already been through this, Valsalva. So now I'm going to deviate a little bit because when I thought we'll include imaging, I cannot leave out neuroimaging, or basically imaging in instances where patient's vision is compromised. So there's going to be a few slides. So typically we see conditions where there is acute loss of vision unilaterally, acute loss of vision bilaterally, gradual progressive loss of vision unilateral, or gradual progressive loss of vision bilaterally. And in each of these scenarios, what is the imaging that we need to do to be able to arrive at a diagnosis confidently? Now, if, say, for example, if patient has acute loss of vision, would you do a CT scan unilaterally? Would you do a CT scan, or what scan would you do? So typically, you must understand that acute loss of vision unilaterally, the area of interest is the optic nerve up to the chiasm. No other lesion anywhere else is going to cause complete loss of vision in one eye. And therefore, the choice of investigation in the absence of trauma should be MRI. However, if there is a history of trauma, to look for bony fractures or traumatic optic neuropathy, CT scan can be done. Contrast is mandatory, especially if you're suspecting optic neuritis and you have the finding of disc edema or something like that to support your finding. The next scenario is acute loss of vision bilateral. Now remember, if the patient has bilateral acute simultaneous loss of vision, your area of interest is post-chiasmal visual pathway. And in these cases, it typically is going to be an aneurysm or a vascular lesion or a stroke that is causing this. And therefore, your choice of investigation should be MRI or an MRA, an MR angiography. Diffusion weighted imaging, especially in the setting of a stroke, can be useful. Now, gradual progressive loss of vision. Now, remember, in this case, what would be your area of interest? Again, it's the optic nerve, but it's a gradual progressive loss of vision. So you'd suspect that it's an orbital tumor that is pressing on the optic nerve or an optic nerve tumor itself. And therefore, you're thinking of compressive optic neuropathy or compressive ophthalmopathy. So you would want to get a CT orbit done first. And finally, gradual progressive loss of vision. Again, you're looking at post-chiasmal visual pathway. And again, your choice of investigation should be MRI. So this helps you get a general understanding of not just orbital tumors and proptosis, but even in cases of vision loss, unilateral versus bilateral, what should be your go-to investigation so that you increase the chances of getting a positive diagnosis. And now we talk about certain fundus findings, such as optic nerve head brucin or unilateral optic discs, where you'd want to get a simple thing such as a B scan or an ultrasonography can help you. When you have a patient with IIH, you want to get an MRI or an MRV because you have to look for whether there is any intracranial sinus that is thrombosed. And if you have a patient with infiltrative optic neuropathy, always get an MRI scan and mention that you want to look for brain lesions as well, because primary intraocular lymphoma can also cause CNS lymphoma. And finally, when you have a patient with hemifacial spasm, remember every patient with hemifacial spasm has to undergo an MRI or an MRA, because although in 70% of patients with hemifacial spasms, you get an absolutely normal MRI scan, in 20% of them, you see a vascular loop around the seventh nerve nucleus or the exit of the seventh nerve. And in 10% of patients or lesser, you see a CP angle tumor, which causes the hemifacial spasm. So don't directly jump and offer Botox to your patient with hemifacial spasm. If it's the first visit of a recent onset hemifacial spasm, always get an MRI or an MRA done. And finally, intraocular tumors like retinoblastoma, to confirm the diagnosis, a CT scan helps. But when you're looking at serial tumors serial scans over time, remember each CT scan is associated with additional radiation. So you may want to switch over to MRI. So I'm going to quickly go through some cases. All right, Dr. Daksh. This is a gentleman with 30-year-old. We saw his picture earlier. A 1-week history of swelling and pain, a 3-month history of reduced vision in a young patient. What would be your first guess or understanding of this? What this could be?
Sorry, it appears to be an inflammatory condition with a chemosis and conjunctival hyperemia.
I agree. It definitely looks inflammatory. So we've at least come down to that. So this was inflammatory, and therefore additionally, because we could not lift the globe, we did a B scan. It showed the entire eye being filled with a mass. We thought of this we thought this is superadded infection, so was treated with antibiotics along with some steroids and topical steroids and cycloplegic. Still, the inflammation reduced significantly. A CT scan did not give us much clues. It just showed ill-defined shadowing along with the displaced lens in the eye. And when we did an MRI, we could see that there was a T1 showed a high signal mass, and a T2 signal showed exudative retinal detachment with again a mass within. Gadolinium enhancement, which is contrast, showed enhancement of the mass lesion inside. This was basically a choroidal melanoma that had undergone tumor necrosis, which presented at orbital cellulitis. So this is a 52-year-old gentleman. Dr. Pooja, what would be your initial diagnosis or suspect? Anyone else in the audience would like to give a differential at this stage?
Sir, it appears to be the bilateral condition, so must
Uh-huh.
can be a cause of severe thyroid eye disease with exposure.
Yeah. So someone in, I think Dr. Priyanka also mentioned, you also answered correctly. This could be thyroid eye disease in the severe active phase. So in rightly in this case, we did a CT scan, and you can see that at the apex, in the picture to the right on top, you can see there's crowding at the apex, and you can actually appreciate the compressive optic neuropathy at the apex. Extraocular muscles are enlarged. And this is, what beverage do you associate with this?
Sir, it is mainly related to the smoking.
I know.
Coke
No,
bottle
not,
appearance.
yeah.
Coke bottle
Coca-Cola bottle appearance is the answer I was looking for. This because the thyroid muscle, the thyroid eye disease, in thyroid eye disease, the muscle, the swelling spares the tendon, and it's mostly on the belly and at the apex, which looks like a Coca-Cola bottle, which hasn't changed its shape over years. So that's why it's called the Coca-Cola bottle sign. That was a little misleading, Daksha. I'm sorry, you thought what beverage consumption is associated with thyroid eye disease.
Yes, sir.
Yeah. So in thyroid eye disease, apart from the active acute phase, and patients can have acute on chronic phases, especially while they are on treatment. You may have seen that the patient's proptosis is resolved after 2 or 3 cycles of immunosuppression, and again has a phase of inflammation. At that point, you can get an MRI done, because that's the only phase that you will be able to actively see different phases of inflammation. Like here, you're able to see all 4 muscles of both eyes involved and thickened, but it's the lateral inferior rectus on the right and the superior rectus and inferior rectus on the left that show increased contrast uptake and enhancement, suggesting that these are the muscles that are currently inflamed and active. And of course, the patient undergoes systemic medication, and he responded very well to that. So this is a 16-year-old boy with a school fight, and you can see he has ecchymosis, and visibly there is enophthalmos. So in trauma, what are things that you look for? You look for the position of the extraocular muscles. Quickly, what scan window, bone window or soft tissue window is this?
Bone windows.
Bone window, correct. So you'd want to look for the orbital floor, whether there is any entrapment of the muscle, whether there is any entrapment or prolapse of the fat without entrapment of the muscle. And in CT scan, you always advise for a sagittal plane or sagittal parasagittal cut, because this will tell you exactly how big is the fracture defect and how big should your plate be. Excuse me, or the barrier that you're going to place during surgery. Now again, you can see the floor being completely, broken, and the inferior rectus has prolapsed into the orbital sinus. Again here, what sign is this called? Any name this has?
teardrop.
Teardrop sign. So what is a teardrop? Basically is that this is a trapdoor mechanism where for that fraction of a second of trauma, the orbital floor bends, gives way, some amount of orbital tissue prolapses down, and the bone snaps back into position. Sometimes it could entrap the inferior rectus, sometimes just the periorbita or orbital fat gets trapped there, and you see that as a teardrop sign that is hanging down. And if the patient has no motility related issues, or you can do an FTT and check, and that's how you know whether the muscle is entrapped or not. Here there is a medial wall along with a floor. Medial wall fractures are cases where you would see typically crepitus and emphysema. And these are the cases that you do not ask the patient to blow their nose, or patients themselves will come and say, I was okay after trauma, then I sneezed, and look at the swelling that has come up, because a sneeze forcefully pushes the air from the airway into the ethmoidal sinuses, and then through that broken defect in the bone wall, it goes into the orbit and the subcutaneous planes. Now, this again is a bone cut, and this is a patient who had trauma, and we've requested for 1 mm slices, because here we can clearly see a bony fragment at the orbital apex impinging on the optic nerve, And these are the cases where you know that this is traumatic optic neuropathy because of a bony fragment that is causing pressure on the optic nerve. So these are things that you need to look for in trauma. Now, 66-year-old moles, sudden onset of decrease in vision, inability to move the eye or open the eye, and he's on treatment for CA prostate. So the sudden onset is what tells you, again, absence of inflammation, absence of any obvious signs of inflammation tells you that this is not an inflammatory condition or an infective condition. It could be an infiltrative or a tumor-related condition. And as you can see, this is an infiltration of the lateral rectus and all the extraocular muscles actually. In CT scan, you would have also been able to appreciate the bony erosion. This on biopsy turned out to be positive for CA prostate. Now, the next case is a patient with a fever and cough since 4 days, swelling and localized pain since 3 days. So can someone tell me what is the top differential diagnosis for this?
Sinusitis-induced orbital cellulitis, sir.
Sinusitis-induced orbital cellulitis. Anything else that someone can say? Anything else that this could also be? Look at the location where you see localized swelling.
Preseptal cellulitis.
Preseptal cellulitis, specifically something more that you see in this region. So the answer we were looking for dacryocystitis. Very well done. Dacryocystitis. So all of these can be common causes. So now I need to know, how do you differentiate between preseptal and orbital cellulitis? A patient comes to you with this kind of picture. Why is it important to differentiate between preseptal and orbital cellulitis? All right, so Dr. D tells us extraocular muscle. So what in extraocular muscles? Do you check for ocular motility? Okay, so if ocular motility is normal, does that tell us that this is not orbital cellulitis? So Dr. Disha tells pupils. So extraocular movement and pupils. What if extraocular movement and pupils are normal? So another thing before I go ahead, it's never extraocular movement.
Proptosis?
No, in the sense, the phrase, it's ocular movements or extraocular muscle motility. Remember, the eye doesn't come out of the socket, go around and come back. It can be extraocular movement. Ocular movement or ocular motility or extraocular muscle function. So in bits and pieces, everybody's answered it correctly. It's important because 3 things that you look for. It's basically pupil, that is pupil or vision or anything which is a surrogate of optic nerve function, motility, and proptosis. Now, if any one of these 3 is abnormal, which means that the patient may have complete motility and no proptosis, but you see an RAPD, it could be early orbital cellulitis. If the patient has motility restriction but normal vision and no proptosis, again it could be orbital cellulitis. And finally, if there is proptosis, regardless of pupil or motility, it is orbital cellular. Usually, you don't see one; you always see at least 2 together. But the presence of any one of these 3 in a patient with localized orbital or periocular infection, like dacryocystitis, like even a STI, or a patient with a known history of cellular sinusitis, this means it has progressed to orbital cellulitis. It is important because in this case, you have to treat with intravenous intravenous antibiotics and not just oral or topical. Now there is, of course, increasing evidence for steroids in cellulitis, in bacterial infective cellulitis. Of course, I don't want you to go out and tell this in your examination. Your examiner may not necessarily like it. But nowadays in practice, once we've identified a focus of infection, like say sinusitis, and we've given antibiotic treatment, if we document an improvement over the first 24 to 48 hours, we usually add on steroids because that improves the uptake of antibiotics and reduces inflammation and resolves very quickly. You can see in a matter of 6 days, the patient has resolved so well. All right, so this is case 6, a patient, a 35-year-old male who's a carpenter and has a history of while hammering a nail, Now here you can see there's a traumatic cataract. What would be your immediate mode of imaging? First mode of imaging?
CT scan, sir.
CT scan, that's correct. You can either do a CT scan or an X-ray. Dr. Venetia has answered CT, that is correct. So here you can see a CT scan is done and you can identify the small speck of mass. Now, here this is a lady with a 6-month-old history of outward painless protrusion of the eyeball. Now, based on this picture, you can see the proptosis, you can see the direction of the proptosis. What would be your number one differential as to where the mass is coming from and causing proptosis?
Superomedial, sir.
Superomedial. So what do you think would be in the superomedial region that is causing
Frontal
painless?
Frontal
mucosal. Frontal mucosal. So this is how, based on the history, based on the appearance, and based on the direction of the proptosis, even before a CT scan, you've already got your diagnosis. Your CT scan is just a confirmation test, and it is a guide for you as to how to go around when you're operating to give you the landmarks. All right. So very well done. And finally, MRI, you would look for in cases of vascular lesions or cystic lesions, or like I said, optic nerve lesions, or in cases when you're pregnant. Now, this is a 7-year-old male, watering, redness, eyelid swelling since 3 weeks. They're carrying around the medial canthus with a palpable nodule over there. And when we asked him history, he said he went to one of those melas in the gaon, and something hit his eye, but nothing else. So based on this, we had a strong history of suspicion, and that's when we sent the child. They couldn't afford a CT. We got an X-ray done, and here is one of those rare cases where, as a screening tool, we can use an X-ray. And of course, eventually we did do a CT scan to assess the exact location with respect to the extraocular muscles, etc. And importantly, during surgery, you can see that the probe is in the canaliculus to make sure that at no point do you even by mistake damage the canaliculus while dissecting that. And it was a BB gun. The child was just passing by, did not realize that someone had shot one of those balloons, and it had lodged in the orbit. So finally, to wrap up this imaging component of this talk, first thing is to decide whether a CT or an MRI is indicated or not. Whether is it an emergency? And at the end of the day, whenever you do a test, you must know what to do if the test shows a positive outcome. So if you are doing a CT scan or an MRI, you should advise that based on what you are going to expect in the scan. Second is decide whether a contrast is needed. Then you need to tell the radiologist what is your area of interest. Remember, you don't need a CT chest or a CT brain when you're looking for an orbital tumor. Any specific imaging sequences or any specific vascular condition that requires special imaging. If you are having any doubt or you want the radiologist to suggest, call up the radiologist and say that this is what I'm thinking it could be. What scan do you suggest? And ask them if additional studies might show the lesion better. They may say that, hey, maybe a CT is not needed, an MRI is better, or you can do this. If the clinical picture suggests a specific lesion or localization and the initial imaging is normal, remember, you can always consider repeating the imaging with thinner slices or higher magnification, essentially higher resolution. And finally, the most important thing that we all need, forget whether it is CT, MRI, OCT, FFA, the lack of an imaging abnormality does not exclude a pathology. So just because the scan doesn't show up, that the patient in front of you has a pathology can still be possible. So finally, we've completed the whole gamut of imaging. We've come to systemic evaluation. And here in systemic evaluation, remember, things that we need to look for is whether there's a visible thyroid enlargement, because as we know, thyroid eye disease is the most common cause of both unilateral and bilateral proptosis. Look for neurofibromatosis, especially when you have children with a small, that we've got kids who've been referred with chronic chalazion, and what you see is that eyelid swelling was actually a soft, palpable mass, which turned out to be a neurofibromatosis. All you need to do was lift up the child's shirt, identify the cafe au lait spots, the axillary freckles, and you would have known that this is neurofibromatosis and not a chronic chalazion of the eyelid. Visual fields, diplopia charting, and photography are important. I think we've already gone through the aspects of photography here of the worm's eye view earlier. I want to spend a little bit of time on intraconal tumors. Now, like I mentioned, there are some certain cases where we know that there's intraconal mass, but can we see the optic nerve? And these are cases where then we'll call up and get an MRI done just so that we can visualize the optic nerve separately from the tumor. Now, there are different ways that you can approach the orbit. The most important thing that decides the way in which we approach the orbit is the location of the tumor. And the most common orbital or intraconal mass is a cavernous hemangioma. They are very well encapsulated, benign tumors with wide vascular spaces. They're typically intraconal and displace the optic nerve. And that is why we typically need an MRI to be absolutely certain of what the diagnosis is, because only a cavernous hemangioma will show you the flow voids. That's the stippling contrast that you can see in the bottom left image there within the tumor. Also, an MRI will help you clearly delineate the optic nerve, as you can see with the arrows showing the tumor separate from the optic nerve. Now, based on this, the image A, you know that your choice of entry would be inferior transconjunctival. Again, in the image D, it's the same patient. That's how you're going to go in. And if the patient has reduced vision, you know that is attributable to optic neuropathy, because look at the image D, where there is a sagittal slice of the optic nerve being compressed by the tumor upwards. So apart from an cavernous hemangioma, the other usual suspects that you may see within the orbit intraconally could be schwannomas, or with schwannomas that can also have sudden cystic degeneration, solitary fibrous tumors, which is an umbrella term for tumors, set of tumors, lymphangiomas, and lymphomas. So now your surgical technique, I'm going to focus on inferior transconjunctival route. Typically, if it's only in the inferior compartment of the orbit, you can do an incision which is marked A. But as a beginner, you want more access. Not forget, as a beginner, as at any stage of your surgical career, better access always improves your surgical maneuverability. So it is always wise to include the caruncular in a transcaruncular incision, as well as including a lateral canthotomy and cantholysis, such that your approach into the orbit is much better. So this is a patient with left-sided proptosis. You can see on the worm's eye view, the significant axial proptosis, which suggests that it's an intraconal mass. And when we did a CT scan, you can see an intraconal mass. Thankfully, in the CT itself, we were able to visualize the optic nerve, and therefore not requiring an MRI sequence separately. Now, there are two ways you can reach the orbit. There is a post-septal and a pre-septal route. Remember, the incision begins just below the inferior 4 mm, just below the tarsus. As a rule, we always advise that you should hook your muscles and tag them, such that you know where the muscles are when you move them and see them in the orbit. Also, at the end of surgery, you can always do an FDT to see if you've damaged any of the extraocular muscles. Like I mentioned, a lateral canthotomy and a cantholysis is a good thing to do to increase the field of view, because it allows greater retraction and better visualization. If you're doing this surgery for the first time and you're unsure of assistance, taking traction sutures creates a permanent traction downwards, reducing the need for your assistant to keep going in. Palpate the orbital rim and then make an incision in the fornix about 4 mm below the lower edge of the tarsus. You would go through the lower lid retractors, and once you go in through that space, directly you're into the orbit. Once you're into that space, use a Stevens scissor or a large scissor to splay open. Remember, do not close the blades of the scissor unless you are directly visualizing. So I'm splaying open the tissue planes and coming out with the tips of my scissors open. Now, when I splay open the tissue plane, I can introduce my malleable retractor such that it helps me retract the orbital fat away. Now, I use the retractors on a hand-over-hand approach such that I'm able to use the tip of my finger to digitally palpate the tumor. Now, as I'm doing that, you can see the purple surface of the tumor, which in this case we suspect to be a cavernous hemangioma, is visible inferolateral to the globe. So this is a case where you would use the third instrument or your third hand, which in this case is a cryoprobe. The same cryoprobe with the retina tip, which is a ball tip that is used. What that does is it fixes itself to the anterior surface of the tumor, and with rocking sideways movement, you are able to break any soft tissue adhesions that it has around. Along with sideways movement, gently pull it upwards. Now you can see that it hasn't come out completely, so clearly try to dissect it all around such that you're able to loosen the tumor from any soft tissue attachments that it has. Intermittently, always check the pupil, because if the tumor is pressing on the optic nerve, traction will cause pupillary dilatation. But in this case, we've freed all the attachments and out it pops in toto, well encapsulated. In some cases, you may also have a small feeder vessel that we need to be cauterized at the end. Doing an FDT is a good idea. You just make sure that there is good hemostasis, and then you can close the wound with 3 or 4 transconjunctival sutures of Vicryl through the fornix and through the lower lid retractors, and also reform the canthus. And most of these cases, patients do very well without any recurrence. So some tips would be that in orbitotomy, stack the extraocular muscles at all stages. As a beginner, it's good to go extra periosteal and then come in. Access is everything, so canthotomy and cantholysis are important. Always check the pupil intermittently to make sure that you don't cause pupillary dilatation when you're pulling on traction. So this brings us to those first 3 cases that we saw at the beginning of our presentation, which is the first case of 55-year-old female, 4-month history, rapidly increasing with pain and redness. All right, so now I want to ask the students, what would be your number 1 differential in this case?
Intraconal tumor.
Intraconal tumor. So would you suspect this to be a benign or a malignant tumor?
Sir, malignant.
Malignant tumor. So you're suspecting it to be a tumor. Your next step of investigation would be?
MRI.
MRI. All right. So we did do an MRI eventually, but we also did was a CT scan. Now in this scan, look at a couple of things. Now I'm going to enlarge this image. Don't see the affected eye. Don't look at the tumor. The tumor is, of course, not at all well encapsulated, is irregular, pushing the optic nerve to one side, causing proptosis. Look at the non-affected eye and specifically focus on the lateral orbital wall. Can you see the lateral orbital wall? Let me try to annotate this. Yeah. Look at this. Can you see how smooth it is? And compare that to this. This is the ragged appearance as compared to that a smooth appearance of that. And I'm going to undo these lines so that you can appreciate it yourselves. That is a sign of bony erosion and bony irregularity. Another subtle sign that tells you that, hey, this could be a malignant lesion. Eventually, we did biopsy it, and it turned out to be a metastatic tumor, which on immunohistochemistry showed that it was a melanoma actually, and the primary was a melanoma of the colon, which had spread to the orbit. So here the key features that tells us it's a rapidly progressive tumor is the 4-month duration, associated subtle inflammation, which is mainly because of congestion, irregular bony appearance which shows bony erosion, as well as the presence of pain and diplopia. All of these suggest a rapidly progressing disease process, which in this case was a orbital tumor. Now, this was the second case, a 46-year-old male, increasing since many years, gradually increasing, painless. Here again, we did a CT scan. We could not ascertain the optic nerve or how close or far it was. An MRI was needed, and we were easily able to visualize the optic nerve and in relationship to the other structures around. Patient underwent a cryotherapy-assisted excision, as we've already seen earlier. It was a cavernous hemangioma. It had a benign course with no recurrence. Now, this was a child that we knew we had repeated episodes of exacerbation, especially during upper respiratory tract infection, typically painless. Can someone tell me what are we seeing in this MRI image? Anyone?
There is inflammation of
Go
inflammation
ahead.
inflammation of soft tissues.
All right. So you see those white, dilated spaces. So anybody else wants to have a go at it?
Calcification of
Calcification. No. So remember, this is an MRI and not a CT scan. So hyperintense.
There are hyperintensities noted on the medial and the lateral aspect of the muscle insertion.
Okay. So this is first thing is that this is a contrast enhanced image. And what we are seeing, so
The dilated vascular spaces, sir.
right. So these are dilated vascular spaces, very well said, and these are contrast enhanced images. And so if there are dilated vascular spaces where contrast that has been given intravenous is going and filling up, these are dilated vascular channels. Typically, dilated vascular channels in children causing proptosis that worsen during episodes of cough and cold is a lymphangioma or more commonly called as a venolymphatic malformation. So what is the best treatment for these cases? Let me just see, someone has entered something in the chat box. Lymphangioma, Prashant, Peta Ravi and Siddhi Mathur got that right. So what would be the best treatment option for this? So now the current best treatment for this is intralesional bleomycin, which causes sclerosing of all these dilated vascular channels. So what we do is it can either be done percutaneously directly, or it can be done with ultrasounded guidance, where we introduce a wide bore needle or in this case a butterfly cannula into the dilated vascular spaces, an assistant in aspirating that, and that aspirates all the blood within these dilated vascular spaces. Remember, these are low flow AV malformation or venolymphatic malformations, so they don't refill as soon as you empty them or aspirate them. And once you've aspirated all of that, you need to take a sclerosant like bleomycin and inject that back into these spaces. The bleomycin or the sclerosant is typically frothed a little bit so that there is a little foam in it, and it increases the surface area and the surface tension. Here, the sclerosant is being injected back into those vascular channels, and over a period of 1 or 2 such repeated injections, you can expect a good response, and the patients do very well. So to summarize, when you have a patient when you know that the pathology is involved in the orbit, you need a tailored approach. So now we know that you cannot just see a patient of proptosis, do a CT scan, and expect the CT scan to show you what you want the answer to be. You need to understand, you need to come to a list of differential diagnosis with history and examination, and then order specific radiological investigations that you can interpret along with your systemic examination findings and ancillary information that you've gathered, come down to an accurate diagnosis. So I think with that, Vishal, how do we go about the quiz? Would you be...
Now the points are, you just, the The residents are not supposed to answer on the mic. They are supposed to answer in the chat box. And whoever answers the first, or if not the first, the most accurate answer will be the winner. So you can put up your
Alright.
slides and you can tell me how many seconds, depending on the difficulty of the question. 10 seconds will be enough.
Yeah. 5 to 10 seconds will be enough. So the moment I complete reading the question, there is one MCQ and two of them are not MCQ based. So you can just
Okay,
answer.
fine.
All right. So your first question here for this group is, what is the name of this exophthalmometer? Okay.
So the time starts now. A lot
Time
of
starts now.
chatter in the chat box.
Okay, so I've seen a right answer, so I'm going to stop it here. The answer question has been answered. We've had one, two, for a change, we've had more wrong answers than right answers.
Yeah, because it's not that obvious. Yeah.
Yes. So this is not a Hertel's exophthalmometer. I think we went through the entire video of Hertel exophthalmometry. Remember where the base was measured? It was at the lateral bony rim. In patients who've undergone facial surgery or have had their lateral orbital rim removed in cases of orbitotomies, and the lateral orbital no longer is a viable support, we use this called as a Noggles exophthalmometer. And the first correct answer given to us was by Dr. Kavita Ghanolia, who's mentioned Noggles exophthalmometer. So she
Congrats,
gets this
Kavita.
one correct.
Yeah. First. You can proceed towards the second question.
All right. So second question is a quick MCQ. Remember, you don't need to type the answer, just A, B, C, or D will do. What is the most common cause of pediatric proptosis? Okay, so again, a slew of wrong answers, and then we got a right answer. Vinish has said A, Ashwini has said A, Akshika Dhamija has said C, and that's the first correct answer that we got, orbital cellulitis. So Dr. Akshika has got it right.
Akshika, are you there?
Yes, sir.
Congratulations. You got the second prize.
Right.
Yes, sir.
Grand prize for the second question, sorry. You got the first prize.
Yeah. And the third question that we have here is, it's a simple one. What tumor is this associated? And name the condition. Give me a full answer. Give me a full answer. That is, name the tumor and name this condition.
The name of the condition and
All right. Okay. So Siddhi Mathur is the first one to tell me the complete answer, which is neuroblastoma with racuna. No, I think Dr. DV has answered both separately but got it correct. So Dr.
DV. Yeah.
DV.
Yes, sir.
Who is
Dr.
DV?
DV, where are you from?
I'm Divya. I'm Dr. Divya, sir, from IGGH Pondicherry.
Pondicherry. Congratulations.
Pondicherry. Lovely.
So
All right.
congrats.
So just one more question. So where is the a neuroblastoma in the orbit? Is it the primary location, or where does it come from, or how does it cause this? Right. So it's in the sympathetic chain or the neural tissue in the abdomen, and metastasis to the orbit, bilateral simultaneous metastasis to the orbit, where it rapidly progresses and infiltrates into the venous channels that drain the skin and the conjunctiva, causing these small hemorrhages and petechial hemorrhage to appear and coalesce to form the racuna. So that was question number 3. Very well answered. I think the participation was very, very good and very interactive. And with that, I'll wrap up. And I did not realize that I did not think I'll take up 1.5 hours. But
So congratulations, Divya, Akshika, and Kavita. The enrolled people will contact you, and the prizes will reach at your workplace. Just to wrap up, this has been a wonderful Kaksha on proptosis as workup and management. It's a very vast topic and impossible to cover everything, but a very well explained and a very comprehensive presentation. Thank you, residents, ROS executive, respected teachers, and especially Dr. Akshay Nair for the excellent teaching today.
My pleasure. My pleasure, Vishal.
We look forward to the next class in the coming weeks with more residents in the hot seat. Thank you and keep giving your feedback and suggestions for the experience to improve. Do subscribe to the ROS official channel on YouTube. All previous lectures, including this one, are uploaded there. Good night from Team ROS. Thank you, Akshay. Bye.
Thanks. Bye-bye.
Bye.